using the hashtag MM50. If anybody is out there tweeting, we appreciate it. It's a great way to have sort of a second conversation about these issues. We are videotaping the event, so if when we get to the Q&A part, please use the microphones. And in the back of the folders, I think it's on the left side maybe, there's an evaluation form, and I know both the Academy and ASA staff worked really hard on this program, and if you could give us some feedback, that would be great. So without any further ado, let me turn over the microphone to Lynn Friss Feinberg, who I think most of you know is a national expert on family caregiving at AARP and also chair of the ASA board.
Thanks, Lee. I'm also a proud Academy member. So on behalf of the American Society on Aging, known as ASA, for those of you who may not be as familiar with us, I'm really delighted to welcome you here to AARP. And I would also like to acknowledge one of our other board members is here today, Bob Lancato. Bob, you're here. There he is, also on our executive committee and co-chair of our public policy committee. We are very pleased and honored to be collaborating with the National Academy of Social Insurance to shine a light on a forthcoming issue of Generations focusing on Medicare at 50. Generations is the quarterly journal of the American Society on Aging. Each issue brings together the most useful and current knowledge about a specific topic in the field of aging, with an emphasis on practice, research, and policy. And I'm especially pleased that the chair of our Generations editorial board, Susan, are you here? Susan Reinhardt? She was here, my boss, who is a senior vice president at AARP and also the director of the AARP Public Policy Institute, is the chair of our editorial board, and Dr. Cheryl Phillips from Leading Age, also a member of our editorial board, is here as well today. As well as Kevin Prindivil from Justice and Aging, I've got the name right, who's one of our speakers. So in celebration of the 50th anniversary of Medicare, ASA is devoting the summer issue of Generations to this milestone event in health policy and practice. The special issue will be released June 15th at the Kaiser Family Foundation here in Washington, D.C., and this issue promises to deliver the timely and insightful exploration of Medicare in the past, the present, and the future. And as Lee noted, we are especially honored and privileged to have Tricia Newman from the Kaiser Family Foundation and John Rother from the National Coalition on Healthcare to be our co-editors. So let me just take a few moments to share a little bit about the American Society on Aging for those of you who may not be familiar with our organization. ASA, as we are known, is the leading multidisciplinary membership organization of over 5,500 professionals who work in the field of aging. Our members are the people who have the hearts and the spirit to work with older adults and their families, representing a wide array of professionals, researchers, policymakers, practitioners, people in business, entrepreneurs, the media. Founded in 1954 in San Francisco, our mission is to be the essential resource to cultivate leadership, to advance knowledge, and to strengthen the skills of our members and others who work with and on behalf of older adults. ASA is also one of the best networking opportunities. I've been an ASA member for quite a few decades now. Our annual meeting, the Aging in America Conference, is a place to connect to leaders and experts from around the country and to have fun too. That's an important part of being a part of ASA. And we hope to continue what we're doing today with NASI to have increasingly more local and regional events and have a greater presence here in Washington, D.C. In your folder, there's the call for proposals for our 2016 Aging in America Conference, which will be held here in Washington, D.C., March 20th to 24th, 2016. And I really encourage you to submit an abstract because we'll be here in Washington. We're really looking to have a lot of policy relevant proposals, and I think Bob would agree with that. Oh, and Rich Brody is here. Rich, hi. Rich is the past chair of the Generations editorial board that made the determination to have the focus on Medicare at 50. Welcome, Rich. So in closing, I thank you for being here today as we all celebrate the 50th anniversary of Medicare and Medicaid and the Older Americans Act, and we welcome the first panel. Please come on up. Thank you.
Can you hear me? Yes. Great. Okay. Well, I am really thrilled to be here. I feel like I'm here with so many friends of Medicare and friends of mine, and it's a great group of people, and I think this will be a really terrific panel. I'm going to start by making a few opening remarks, and then I'm going to hope to spice it up quickly with some interesting perspectives from my wonderful panelists. Before I do, I want to thank so many people, but I'm just going to thank AARP. I'm going to thank Lee, who did so much work in putting this all together. I'm going to thank my friends from ASA, who are hiding all over the place, and for their great support for a really interesting Generations issue, which is coming out this summer, and several authors are in the room, and I want to thank you too. Because I think it will be worth reading and a sort of a great start to Medicare's next 50th. But we are here to talk about the beneficiary experience. And I will just say a few words about our panelists. I'm not going to give you their extensive bios, but we have with us, moving from the right to the left, Kevin Brindlevold from Justice and Aging, the new and great name for his organization, who is fantastic. We have Joe Baker from the Medicare Rights Center, who is here, also wonderful. And we have Judy Stein from the Center for Medicare Advocacy. And I was thinking how funny it is. So we're here to celebrate Medicare. And if you think about that, we have three people who probably know more about the problems of Medicare than anybody on earth. If you think about what they do all day, they really hear people fetch, because why else would you call these people, right? I mean, you call them to invite them to speak, but you also call them when you have a problem because you have a parent who has an issue or you have a friend who has an issue. I know I have called on each of them at different times. And yet, what these three have in common is such a strong appreciation for the role of Medicare, a profound appreciation for what it has done, and a deep commitment to making it work in the future. So while I'm sure we won't hear a total all happy talk this morning, I think what we will hear is this afternoon, a great appreciation for the Medicare program and what it has done for the health and retirement security for so many people on the program, seniors and younger people with disabilities. Very, very quickly, I am going to start by just putting us all back in the frame of mind of who we're talking about. I know many of you know this, but some of you may not, and I just want to take us back to what matters. We're talking about a program of 55 million people today. If you blink, the number goes up by a couple million. We're now at 55 billion. It is 14% of the federal budget, and it is 20% of national health care spending. So this is a big issue. and it is a big issue for people, and it is a big issue in politics. But let's get to people, because that's kind of what this is all about. Let me try to get to people. Yep. Okay. Well, okay, let's just work with this. It's a little bit odd because it seems like 2 slides in one, but I think you can get the point. And so what does this tell us? When you think about the Medicare population, we think about a diverse group. We should think about a diverse group. Many people are healthy, but many people are not. So as we think about making the program work, it needs to work for a diverse set. Nearly half have 4 or more chronic conditions. About a third have one or more functional impairments. About a third have a cognitive impairment. And 26%, a quarter, are in fair or poor health. So when we need to make the program work, we need to make it work for people who have who are in various situations. We also think about a population that is diverse in terms of income. This issue of income matters a lot because the concept of affordability is so important when we talk about the debate over Medicare's future. We hear a tension in Washington, and we're going to come back to this in this panel. There's this concept of affordability. What can the nation afford? That's one question. That's a budget question. Then there's a question of what can people afford? So when you look at the slide, what you actually can't see is the median number, and which is half of all people have incomes below $23,500, and a quarter of all people on Medicare have incomes just below $15,000. While there are certainly people who are wealthy, and many of the people in this room may know folks who are wealthy, again, this is a situation of trying to make the program work for people in different circumstances, and so we think these are numbers that are important to understand. Likewise, it's important to understand that not everybody is average. And often we talk about people, well, the average person on Medicare is this, the average person is that. But many people are not average. So look over at race, ethnicity. I just said that median income is at $24,000 per person or less. When you look at by race, ethnicity, you see that median income is significantly lower per person, a little bit less than $17,000 for Black Medicare beneficiaries and less than $14,000 for Hispanic Medicare beneficiaries. You see median income declines with age. You see median income is lower for women than men. I could show you this for savings. I could show you this for home equity, because often people are saying, well, yeah, but people have a lot of money in the bank. What you see is a very skewed distribution. Some people are wealthy. Some people can afford whatever you throw at them, but really many people cannot. So this is an issue in Medicare, as we'll talk about, because there are plenty of people because Medicare doesn't cover everything. It's a decent program. It's not a Cadillac program. It doesn't have a limit on out-of-pocket spending. It doesn't cover hearing aids, eyeglasses, dentures. Sorry for that picture, but we think it's kind of, I don't know. Graphic, exactly. Obviously doesn't cover long-term care. It still has a donut hole, though not for terribly much longer. So it's an issue for people, and people buy supplemental coverage, but guess what? That costs money too. So people on Medicare do have considerable expenses, and that is an issue to think about going forward in trying to strike the right balance on affordability. Here what you see is that this compares Medicare households to non-Medicare households. Medicare households are on the left, non-Medicare households are on the right. And what you see is that Medicare households are spending a lot more on health care than non-Medicare households in dollar terms as a percent of their household budgets. You know, people say, well, so what? You know, older people get sicker. Of course, they have more expenses, but what you can't forget is they also have other expenses. You don't stop paying your mortgage. You don't stop paying your rent unless, of course, you want to get kicked out. You still can have a tree fall on your roof and need to have money in the bank for that. So it is a concern for many people on Medicare. And this shows you what happens with out-of-pocket spending. So on average, out-of-pocket spending on services is about close to $5,000, the bar on the left side, but out-of-pocket spending is higher for women than men. And out-of-pocket spending, I'm so sorry that none of the labels have come out, but whatever, rises with age. Out-of-pocket spending is a concern for people on Medicare. Again, with or without supplemental insurance, it remains an issue. This is work done by the actuary. They've looked at Medicare premiums and cost sharing as a share of Social Security benefits, and what you can see over time is that the financial obligations of individuals, just looking at Medicare obligations as a share of Social Security, has increased from 6% in 1970 to 12% in 1990 to 26% in 2020. Oh, she turned out okay. So what will the future hold? I just love that lady. I don't know why. Well, that's part of what we're going to talk about today. I will tell you that when we look about, one thing that we wanted to look at is the next generation going to be wealthier? Should we stop worrying so much? Because when these boomers retire, they're going to have a lot of money. They have saved, they're wealthier, they have invested. We contracted with the Urban Institute, who have a Dynasim modeling model, and they do projections for Social Security, as many of you know. And here's what they're telling us. What they're telling us, and I want you to focus on the black line on the left, which is the 50th percentile. You remember I told you median income is at about $24,000. So what you can see in that line is it's going to rise. Median income will rise, but not by very much. Really, the wealthier get wealthier. There's growth, more growth at the top. If you look on the right, you see a similar story. Assets will rise. That's the good news. But really, much of the growth is going to happen at the high end. So the good news, I guess, is that when many of us are on Medicare, we'll have a little bit more income, we'll have more money in the bank. The bad news is not so much. And so thinking about how to finance care for an aging population and make it affordable and make it good quality is the big task in front of us. And that is my segue to the three fabulous experts who are going to tell us how to address all of these issues. But I was going to start. I'm not going to start by asking you to make opening remarks unless you're just. Are you burning to say something? No. Then I'm going to just take us to where we are today and get these guys going and women going, because when they go, I just need to get out of the way. So this was a big couple of weeks in Washington for Medicare, because we actually passed the SGR bill, and I am guessing that anybody who is in this room is here because they know enough about Medicare to know that we've had a problem with our Medicare payment formula for physicians, and that has been a grueling issue, and we've had 17 short-term fixes in 11 years, and it's been a problem that people have wanted to address. As leaders of senior advocacy groups, I guess what I want to ask you is, was this a good win for seniors? Was this a win for your organizations? And what lessons have you learned? And I will start with whoever. Judy Stein would like to start.
I will put this on, or is this on? It's on? Okay, great.
No. Mine's on, so here.
No, turn yours off then.
Oh. Use mine.
All right, I have Joe Baker's microphone. Kevin, you will have it when I'm done. First, it is wonderful to be here, and I count the three people here with me among my greatest allies and colleagues. And we often simply help one another with different materials and share resources. And I can tell you that we at the Center for Medicare Advocacy couldn't do our work without Kaiser Family Foundation. And that's true. The data that you all provide is absolutely invaluable in proving, knowing what we need to know, proving what we hope to prove, or knowing that we can't prove it. And I thank you immensely. Also, Kaiser Health News is a blessing in this world, given what happened with the news media in particular over the last few years. And Trish is a fantastic colleague. So I say that truthfully. Also, I am a proud member of NACI, and I thank you for the invitation. SGR, the Sustainable Growth Rate, the doc fix, and MACRA, is that the latest thing? The Medicare and CHIP reauthorization, sort of CHIP bill. So I speak to you, this was one of the most difficult conversations my staff and I had about last week when the Senate bill was up. And my conclusion, my organization's conclusion regarding SGR led us not to be at the garden party. And that's because we concluded very reluctantly and after a great deal of thought that it was not good for Medicare, not good for Medicare beneficiaries, and these are the reasons. We are very, very concerned that what the Medicare components of the bill did, and I'm married to a family doctor, by the way, it gets the nose of the camel under the tent, once again, with regard to premium, income-basing premiums. We kept hearing that income would be taken into account in Medicare, but you all know that Medicare, since 2006, has had premiums based on income. So it further income-based premiums. It also buys into a wrong notion that if you have less help through Medigap, you will be less likely to take advantage of unnecessary services by people who purchased Medigap in 2020 will no longer be able to get, quote, first dollar coverage. Have we learned nothing from the donut hole? In Medigap, you're getting coverage because Medicare has already determined the services that your doctor ordered are reasonable and necessary, and what you're looking for from Medigap is coverage for the cost sharing. And this bill would require that no Medigap bills would pay the Part B deductible. Those things are going to further move people to choose Medicare Advantage plans because they will be less expensive, even less expensive than traditional Medicare than they are now, and less complex. And Tricia just mentioned that there are 55 million Medicare beneficiaries. Well, there are actually 55,000,001 Medicare beneficiaries, because I am one of them as of last week, and I have done the math. And I know how expensive traditional Medicare is now and will become. So I think that there were people who knew that what was happening through the doc fix Medicare provisions was to further move people towards Medicare Advantage, further privatize Medicare. I think that's terrible for taxpayers as well as beneficiaries. Also, the therapy cap repeal, which we firmly support, ardently support, particularly as attorneys in the Jimmo case, which is trying to get improvement taken off of the table for coverage. The replacement of the therapy cap, and I won't go into why because I'm taking too much time as it is, was maybe worse than the repeal, than what we have now, which I think is terrible, the cap on annual dollar cap on therapy. You take that, put it together with no request, what you would call ask from the prescription drug companies, no negotiations, no rebates back, and no cost to Medicare Advantage insurance companies. And And I think it was not a good decision to vote for that bill for Medicare and Medicare beneficiaries.
So how can I agree with everything Judy said and still we went to the garden party, you know? So I think the calculation on our part, as I said, agreeing with everything Judy said, we were happy to see QI, the Qualified Income Program, become Qualified Individual Program become permanent. We wanted that to be increased, the eligibility levels to be increased there, and that didn't happen. We had a whole list. We all had a whole list of, you know, our Christmas ornaments to put on that tree, and as Judy's saying, not a lot of those things happened. Our, I think, calculation was in a couple pieces. One is that this issue, this SGR issue, had been so corrosive to the Medicare program. You know, we hear from about 1 million beneficiaries a year in various ways, and every time the SGR came up for renewal or debate, you know, doctors were telling folks, well, we might not be able to take you as a Medicare patient anymore, or boy, you know, I'm not going to be able to take on any new Medicare patients. Medicare is really going to hell in a handbasket. And it was really undermining, I think, people's confidence in the program. So we really felt this needed to be fixed for that reason. And then secondly, because it, and I don't think anybody disagrees that it needed to be fixed, but, you know, and so that was one piece. The second piece was, you know, I don't know how to say this except to say it, and because it wasn't, the fix wasn't fully paid for. So, I mean, you know, it was also in the sense that we're getting this done. It's a bipartisan deal that has all the bad parts of it. The good parts of it is we're not doing other cuts and more cuts, and it's not going to be a flashpoint in the future for various folks that are opponents of the Medicare program to really get their stuff together for another fight and try to get their bad, you know, ornaments on the tree. So that was where we fell down, or that's where we, you know, made our decision and decided to come down in that category. But once again, with all of the same reservations that Judy's discussed.
Yeah, I think that. Can you hear me? Is this one working? All right. What we found interesting about what happened with the SGR is further reinforcing the value of events like these and repeating all the thanks to everybody that worked hard to make this event possible. The biggest thing that's happened in Medicare for several years really happened without much consideration of the beneficiary. And it speaks to a certain alignment of the politics that, you know, we all take advantage of and appreciate the opportunities to collaborate on a program that impacts so many different sectors, right? There's beneficiaries, there's providers, there's health plans, there's pharma, and at points the interests of all of those entities can point in the same direction. But it feels, you know, one of the themes of today that you'll hear from all of us is the increasing complexity of the program. And with the increasing complexity, that sense that all of those entities push in the same direction is not always so. And I think this SGR bill was a great example, an opportunity here to fix the SGR, but to also address inadequacies in the program around affordability or coverage. You know, and we saw where the priority laid. And increasingly, it feels like we've got a program that's owned most by providers and health plans, with the beneficiaries really being a secondary or tertiary, if at all, consideration of the program. And so that's something that, you know, hopefully events like these and our work and partnership, you know, that a recognition of where interests lie, right? Like Joe and Judy both said, it was good to fix the payment problem. Like, that's a good thing for doctors and that's a good thing for beneficiaries. But finding more opportunities where the beneficiary interest is the primary one. And it's, you know, the sort of bad news, as they each pointed out, is it's getting harder to do that. It's getting harder to make movement on issues that are really the ones most important to the beneficiary. When it's a beneficiary improvement around affordability or coverage,
what's the pay for? But here we just saw a massive bill passed that, you know, that question wasn't fully answered. We never get that shot. You know, so how do we put the beneficiary really at the center of the decisions we make about this program?
Before I go on to a completely different topic, are there lessons that you've learned for the next time? Or would you like me to go on to a different topic?
You started with a pretty depressing topic.
I think it is as the gender-based microphone situation. I think Kevin kind of summed it up. It used to be that Medicare was first and foremost about Medicare beneficiaries, about the older and disabled people we represent. And that really isn't the case any longer. And I don't know how we can get that heard. And we didn't get it heard this time. And the other big thing that we ran into was a heady discussion about the therapy repeal bill piece, which we have really, really wanted. As you may know, there's a $1,940 annual cap on physical and speech therapy combined and occupational therapy, and then you have to get an exception and appeals if you want more than that. And one of the amendments the Senate supposedly was going to vote on, but they didn't, was to repeal that. But then if you looked at the bill, which we got at 4 p.m. of the day before it was to be voted on, the replacement, it took me and my colleagues less than a half an hour to realize, oh my God, though, it's terrible. From the beneficiary's point of view. From the provider's point of view, it would have been less onerous and more certain. But a prior authorization program, which is what the replacement would have been, is more and more really, folks, a prior denial system. If you have to get a prior authorization, and it said as defined by the secretary, when the secretary wants, well, pretty much that was the language, and it might include a dollar amount, then you're going to get back to you need somebody to open the gate to let you have the service. And the gates are closing, sort of like at the end of Yom Kippur. The gates are closing more and more on coverage, and the appeal system is terrible. And so I think that's the word, these nuances about what's happening to beneficiaries that Joe and Kevin and a number of our colleagues here know about, but the world doesn't know about, and we're not getting heard. And what providers need is not necessarily what beneficiaries need.
I think that's right. I think, you know, Kevin and Judy have kind of got the two pieces, and that is that, you know, the beneficiaries weren't at the core of this, you know, bill, and when we tried to, even there was beneficiary benefit from it, as I was saying earlier, but, you know, when we tried to, you know, kind of get some other stuff that usually rides along with this bill, right, the extenders, as they're called, when you looked at the fine print, it was really provider-driven and not beneficiary-focused. And so, you know, the question really, the lesson learned is that, you know, while we got something in the pay-for category in the sense that there wasn't some more onerous cut to the Medicare program, you know, the $100 deductible, et cetera, is still bad from our standpoint, and a cut in that regard. But it's, we still don't have, and the lesson learned, I think, really is that we did not have this kind of upswelling of like popular, okay, let's get some good stuff done here, or even a lot of support on the Hill for that good stuff. So I think it really does focus our attention on, if we're going to get this, you know, program improved, it's going to be, as we all know, but I mean, maybe even a heavier lift than we have ever had, and so that's something that we're going to have to grapple with.
Can I ask you all, Kevin and Joe, is this okay? Yeah. One of the things I thought, as we thought through the SGR, I remember saying to David, well, what if it didn't get fixed? And how bad would that be? And because they would patch it, you know, and that was one thought I had was, well, on the one hand, we don't have this hanging over our heads, and on the other hand, they don't have it hanging over their heads, because we would every year hope that we get something good for beneficiaries because they would have to pass at least a patch.
Yeah, I think, as I said earlier, I think our calculation was it was corrosive, over, and, sometimes it was 6 months, right? And not even a year. I think you could go the other way. I think also it was happening. It was going to go down. So, why not, leverage somehow, as we all did in our own way, to try to make it as good as possible. And so I think, it could have been worse. I think absent our advocacy, and sometimes that's the win. But I think, once again, I think we all have mixed feelings about it, and that's where you end up.
Right, and certainly the ability to demonstrate the ability to fix a problem with a program like Medicare that didn't come at the cost of significant cuts to the services or cuts to beneficiaries on on the level that we've all heard proposed.
Yeah,
so that's a lesson learned, hopefully, in a positive takeaway, that there's ways to address some of these problems that don't come completely on the backs of beneficiaries.
If I may. All right, I'm going to talk about I'm going to talk about something totally different. But it's another issue where I'm wondering about whether the beneficiary experience and the lens is something that's on the surface. And that's the topic of delivery system reforms. So there's been a lot of action, relatively speaking, since the ACA on various delivery system reforms and payment system reforms that are being implemented and tested throughout the country. ACOs, bundled payments, independence at home, the duals demos. I could really literally go on and on and on with a long list of things that the CMMI, Center for Medicare and Medicaid Innovations, is doing. My question is, how much is the beneficiary experience front and center in these discussions? I get lots of emails from the health insurance industry about the duals demonstrations. I could go to conferences several times a month on ACOs and what they mean for hospitals. So how much are beneficiaries and their advocates involved in understanding what these payment and delivery system reforms mean for people?
I think
I was going to actually ask Kevin to start on that one.
I was going to say Kevin's doing the dual stuff.
Yeah, I think that's a great question and a great thing for beneficiaries and their advocates to be thinking more about. We feel that there's definite need for improvement of the delivery system. That Medicare is a wonderful program that's meant a ton to all Medicare beneficiaries, especially lifting beneficiaries out of poverty by helping cover their health care costs. But it's, we all live in the healthcare system, and we all see how it's broken for us, and imagine being someone with more chronic conditions and more health needs. So we think there's really need and opportunity to improve the delivery system for Medicare beneficiaries, and we've done a lot of work on efforts in a number of states to improve delivery system for dual eligibles, people that have Medicare and Medicaid. And there's a recognition, I think, from the federal government, from state agencies, from health plans, from providers, that understanding and crafting programs around the beneficiary experience is important. But translating that recognition into action is where, even with the best intentions, people are tripping across the board. And so I think to the answer, I think there's this, to the question, there's a recognition that we should, but it isn't happening yet. So I'll share a story of something that happened in California last week with its dual eligible demonstration, where dual eligibles have been enrolled into managed care plans with the promise that the managed care plans would come in and provide one of the things that's been missing to beneficiaries, which is comprehensive care coordination and someone to help you out as you try to navigate the system. We had a long-term care facility in Southern California that was decertified. It lost its licensure from the Medicaid program, so Medicaid could no longer be a payer. And that normally triggers a series of events where people that are residents have to be transitioned out of that facility. They don't always have to be transitioned out. It's quite complex, but a series of rights that trigger, et cetera. Well, the state agency told the health plans hey, we have a facility that you need to get people out of immediately. The health plans sent notices to the beneficiaries, in many cases without ever meeting with those beneficiaries face-to-face, sent them notices that said, tomorrow you're being moved to this facility 40 miles away, far enough away that your family will no longer be able to visit you on a weekday. This is Los Angeles, so 40 miles away, could be 4 hours away. People were packed up. There was a woman who was on Easter morning, was actually discharged to a hospital despite not having any need to go to a hospital, discharged to a hospital because that would make it easier for the next facility to get Medicare coverage. Spent 3 days in the hospital, then was moved to a new facility. It took a week before she had her belongings from the previous facility that she'd lived in for 3 years. Now, as we've worked through this with the state and the plans, everybody had the best intentions, right? That the plans thought that people were in immediate danger, wanted to get them out right away. The state thought they were in immediate danger, wanted to get them out right away. Everybody thought they had done a great job, but nobody had stopped and talked to the people about what they wanted, kept them at the center of it. Nobody had checked in with the local long-term care ombudsman to understand, to get information about these people, about the facility, about other facilities that they could move to. So the intention is there. But still, so many of the decisions we're making, and this is in the SGR bill too, so many of the decisions that we're making around payment and what's going to incentivize providers, it's about what's going to incentivize providers. It's not about what people need. And there's an instinct from many that those two things are going to match up. But the reality is that they don't always. And so more work needs to be done, we think, to really, not the question be how do we incentivize the provider, but what do the beneficiaries want providers and actors to do? And then decide how we incentivize to that.
I think all that's true. We're doing the duals work, and Kevin is doing it nationally, and with Community Catalyst funding, we're doing it in New York and in specific. And there's some issues of, I'll focus on the positive in New York, and that is we have an incredible amount of state-funded ombudsman funding. And so one of the things that is happening is this delivery system is really, you talk to plans, you talk to providers, beneficiaries maybe for the best part don't know anything's really going on. I'll get to that in a second, but plans and providers are confused and feel overwhelmed, and we feel overwhelmed, let alone beneficiaries. But we definitely need more money for the SHIP program, for ombudsman programs, for all our programs, every program out there that's helping people navigate this world, because it is becoming that much more complex. I think the scary issue for me, and scary is maybe a strong word, but I get scared, is that in the old days, let's say in the 90s, we had providers and we had plans. When Medicare Plus Choice really roared forth and folks were pushing back against that, you felt like, okay, my doctor will be with me in my appeal, and if that plan does wrong or Medicare does wrong. Now, and so you had the white hats and the black hats, if you will. Now it's kind of gray hats, right? Because the doctors are with the plans and with the hospital and the ACO, and the FIDA plan or the duals plan kind of is controlled by the nurse. Like in New York, a lot of nursing homes and other long-term care providers, traditional providers, have created plans. So are they a provider or are they a plan? Who do you go to? Well, you come to us, hopefully, right? Because we're in the ombudsman program in New York, and we're independent, not-for-profit organizations, but people don't know about us. People think, oh, my doctor's still going to fight for me. And you know what? I think most doctors will. Don't get me wrong. I'm not impugning doctors. I'm just saying the incentives, as Kevin was saying, are blurred and not as clear anymore. And finally, I think first of all, we had a big fight with ACOs and to a certain degree with the duals program just to make sure beneficiaries did know what was going on. Because a lot of folks in federal and state government were like, let's just do it. Yeah, just do it, and it'll all be good. So they won't need to know, and we don't have to worry them, And I'm like, wait, there's incentives changing here. They need to know if they're, who they can depend upon and rely upon. And, that, I think, and so they're at the table. We're at the table to a certain degree. But they're not really engaged. They are not really involved. They are not really taken into account in the way that they should be in implementing and developing these programs.
In Connecticut, we follow this nationally, but we also have our field work in Connecticut, and it's been like follow the bouncing ball. We had the governor come in and move all duals out of managed care plans in 2012, 2010, and he was roundly applauded for that. And now with budget cuts, we're looking to move dual eligibles back into what we don't call managed care plans, but are managed care plans. And complex care committee is setting up new plans. And then now this has been studied for a year and a half. We've been somewhat participating in that, and then there's no money for further work, and so they're thinking of just leaving everybody where they are. But where they are is all changed because the hospitals have absorbed most physicians' offices in Connecticut. In the field mix of choices so different than it was just 2 years ago. And independent, as Joe was commenting, doctors are hospitalists, or their practices or community practices are involved with the hospital. It's just completely different. And we must have gone through at least 6 months of argument just about, with regard to the duals, whether that should be opt-in or opt-out, and whether it would worry them to be told, and if you didn't give them a choice, there wouldn't be sufficient numbers in the plan. And then we said, well, if it's so good, why wouldn't they opt in? So you can hear it's very complex, and I think that the patient is really befuddled.
I just, Tricia, one thing, and to that point, is we're working right now in New York. Some guidance has come out. So if you look at in Crane's Health Pulse today, which is a New York rag that we all read in the healthcare world up there, big numbers of people have opted out of the duals demonstration program in New York, and this is not unusual given other states' experience. New guidance coming out on marketing basically saying, oh, okay, plans, you can contact those people to ask them if they do want to enroll again without any kind of like time limit or period. And we're like, no, wait a second, they've opted out. Leave them alone for at least a year, and if that's what they've done, similar to what we do in the open enrollment period for Medicare in picking plans. And so folks are confused. I mean, this is, Tricia had her slide up there about folks with cognitive impairments, et cetera. And this is the dual eligible population, so it's a different slide, right, really, that we're talking about. But I'm just talking about 65-year-old retiring CEOs call us all the time because their HR department gets it wrong. Or, they like, I've got 30 Part D plans to pick. What do I do? So
I wasn't planning on asking this question, but Joe, you mentioned consumer engagement in some respects. You say, consumers aren't engaged. I guess I want to engage you guys and Judy on...
Guys is gender neutral.
Really?
Yeah.
So I was just in a meeting where they said men is gender neutral, and I was like, I don't think so.
I'm gender neutral. I'm fine with it.
I told you this was going to be a fun panel. But there is a lot of energy around the term consumer engagement. And when people talk about reforming Medicare for the future, they talk about engaging consumers to be more active in their health care and in their plan choices and in a range of decisions that were not so necessary years before, or maybe not such a priority in years before. I guess I'd like your take, because you are as close to people as family members are when it comes to engaging the consumers and the phone and people who call you, on your thoughts about this.
I mean, I think I can be very quick because I've talked about it a little bit already. I think there's three types of consumers, there's three types of people. One that really want to do everything, one's that are somewhere in the middle, and ones that are just like, I'll do whatever my doctor's a god, or and usually it's the doctor or nurse practitioner or PA, and I don't want to know anything, I'll just do what you say. And I don't think that's really changed that much. And I think the problem is, once again, is that white hat black hat thing, and there's not that person in the healthcare system that folks feel that they can really depend upon. and where's the right information and the strong information for them, and who's on my side. And then secondly, there's so much coming at them, marketing, et cetera, and so much information that what we find, and this is well documented by work that many of us and you have done, folks give up. They just throw up their hands, and particularly about plan choice and plan switches. Most people don't when they should. And it's kind of like when you go to buy a new car, right? I mean, I don't know about you, but I'm not a big car person, but like at a certain point, you're just like, oh, buy the damn car. I mean,
gray.
Yeah, gray. Give me gray, and I don't know what it costs. Just give it to me. I can pay for it. So I think that's where people are. And to engage them more, what they really want to be engaged with is their care provider, and what they really don't want to talk to other people. And all these care coordinators who are great, but if they're phone people, if they're letter, first of all, if they're just sending letters, and that's called care coordination, shame on them. And then secondly, if it's just somebody on a phone, no, it's got to be somebody, that's got a direct line to their care provider, whether it's a doctor or a PA or whomever.
Yeah, I would just add, I think there's different levels of consumer engagement, and that word gets used the same. I don't think we can ever expect consumers to really engage in designing the intricacies of ACOs and payment incentive structures. They should have a voice at the table through groups like ours and others in this room to really have a voice to represent their interests. But just like the plans send their lawyers, these people should have advocates to send that are educated and informed, and if there's any funders in the room, funded to play that role. So that's one level of consumer engagement. The other level of consumer engagement is this more in their own personal care. And there too, it seems like in DC, the conversation is, show them what the cost is so they can understand the cost when they make their decision, or make them responsible for, being healthier and therefore reducing costs, and give them a benefit. On the policy side, there's great advancements in the requirements around person-centered care planning and person-centered care provision, which is really asking people, and Atul Gawande has done, great work that's gotten a lot of attention about asking people what they want in non-medical terms, asking what their expectations are for their life, especially for seniors, the end of their life, or for people with disabilities, what does a fulfilling and independent life mean to you? And then structuring their care around that. I think that's a place where we should be investing in. That is rarely called consumer engagement. That's called, person-centered care planning and provision, and really talking to people about what they want from their care. And that is shown to be related to reduced costs, because generally people end up choosing, once they use that lens, things that aren't expensive, and that they make good choices.
So I'm going to ask one more question, which is my segue to give you time to think of questions you want to ask. So hopefully these guys will give fast-ish answers, and then you'll be ready, because it will be your turn to just stand up, and then they'll go. You don't even really have to ask a question. This is a panel that will let it rip. So I've asked each of you this before, but you can change your answer. I asked if you were king or queen of Medicare for the day, and today is your day. And you could make one change for the future, and I'm speaking slowly to give you time to think. If you could do one thing and make it happen, and Congress didn't have to vote for it, and the president didn't have to sign it, what would that be?
Well, in the writing, which you'll have to read the periodical, I morphed one thing into a bigger thing. And I've thought hard about how to say one thing that really is multi, but add a prescription drug benefit to Part B in traditional Medicare. That would help save the program, because it would help people stay in traditional Medicare. It would make it simpler for them. And I think it should be with negotiating drug prices and getting Title 19's Medicaid's rebates back, so it would also be a saving to Medicare and for tax people in general, and would make for a much better traditional Medicare benefit, and add dental coverage.
Yeah.
That was not really one thing.
Well, please
we'll
read.
We'll go with the Part B of RX as I said it, that holistic way, if I can only do one thing, and add dental coverage.
I like Judy's answer. I think that's one thing, actually. And I think Judy has the best answer to this question in the article, because basically she says that, but in an even better way, because she lists everything more concretely.
The editor is very lax.
Yeah, very lax, which is fine as far as I'm concerned. I do want to be queen of Medicare, so to keep the gender thing going. And I would agree. If I had one thing, we could do it through Part B. We talk about in the article Part E, and Marilyn Moon, who's on our board, and others have talked about Part E, and basically making the traditional Medicare program, folding Medigap into it, as a public option, public program, Medicare, Medigap, Part D, putting an out-of-pocket limit in there, et cetera, and go toe-to-toe with the MA plans, in that regard. And so I think that simplification, we hear a lot about simplification of the Medicare program, and, a lot of folks are out there, saying, oh, this is a good thing. We agree. Simplification, how can you be against that? The problem is when you parse the proposals, most of them add costs to consumers. It's a way of kind of shifting costs to consumers. It's hard to do without shifting some costs. There's always winners, losers, but I think that public traditional Medicare program with the prescription drug benefit, as Judy's saying, if that's the one wish I get, that's it. With dental. Yeah.
I feel like we should all have stickers that says, with dental.
Put those teeth back up there.
Ew.
Yeah, for us, it's doing something about affordability. When we look at the numbers that Tricia shared that show the increasing economic insecurity of seniors, especially in that bottom quartile, what we would do is raise the cost, the income levels for the Medicare savings programs, get rid of the asset levels, make the program comparable to the great benefits that we now have for people under 65 that need help paying for care. Let's not surprise people when they turn 65 by increasing, we know that their cost sharing is going to increase because their healthcare expenses are increasing, but let's not also increase the percentage to which they're expected to contribute. So that's what we would do on affordability. And since everybody else is throwing in dental, I'll add, do something about long-term care. Do something to get Medicare to reflect, the reality of a robust LTSS program that includes generous home and community-based services benefits.
Okay, the world's better already, wouldn't you say? Okay, so are there mics in the room? There are mics in the room, so do you want me to? Okay. Can you introduce yourself to everybody in the room?
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also an attorney. I've watched the delivery system reform and the payment system reform, and I think it will add a lot of cost without adding very much value. Have you considered there are ways to strengthen the traditional decentralized Medicare system by changing coding, changing, paying more for things we want and paying less for things we don't want? That will do two things. It may reduce the cost in the near term, but over time, if you pay more for talking to patients and less for cutting on patients, doctors will move back into talking. And it's not just about primary care. You want your cardiologist to talk to you more than you want him to take you to the cath lab.
Yeah, I think, there has been some movement in that direction by Medicare and the traditional Medicare program, paying for care coordination, paying for the talking, as you're saying. I think what happens, and the force of that, first of all, it's kind of too little, right? But the force of it is somewhat blunted by all this other stuff that we've been talking about, and the ACOs and the fact that, everyone's affiliated with a hospital, not just affiliated, but an employee of a hospital, and electronic. So it's this avalanche of change that, we've brought into the healthcare program that we don't know what's working, and we don't know, you don't know which switch to toggle or turn off because they're all firing at once. And that's, I think, now I don't think that's just our opinion. I mean, I talk to physicians, I talk to plans, I talk to, all different types of providers, and they're in the same place, really. And I think that's a real concern as we move forward with the Medicare program, is kind of like, how are we going to know what's working when it's all happening at the same time? So.
Is there a mic back there? Oh,
Yes.
I owe you one.
I'm Harvey Feinberg. I'm also a physician, and I listened to Trish Newman's question very carefully. It didn't involve the Congress. It didn't involve the president. And clearly the answer is single payer, improve Medicare for all on both sides. Everybody, I know everybody here is doing good work and knows all about single payer. And that seems to be what we're all asking for. That simplicity, it's not hard to understand. Numerous studies show that universal care is basically GNP neutral, more or less. And that's what people don't want to think about medicine, money when they need a doctor. They don't want to think about how much the police cost when they call 911 or the fire department. They want to get to their practitioner, get well, and it's up to the political thing to come up with the numbers. We know the Republicans are trying to defeat Medicare, and I saw all the torment in thinking about the SG, not even mention the bonus system. They want doctors to start running around trying to get a tip for all their work they're doing by this MIPS plan. So that's the answer to Ms. Newman's question, I think. Thank you.
Thank you. Sorry,
Yeah, my name is Pat Killeen, and I agree with the physician here that a single payer would be the best system. Oh, by the way, I'm a volunteer advocate with AARP. And but back in the 1970s and 1980s, I was senior healthcare consultant for the United Auto Workers Union, and my boss, Leonard Woodcock, who later became ambassador to China, was president of the Committee for National Health Insurance, and we were working for the Health Security Act, you probably remember. But what I really want to get to is how, on a program as big as Medicare, 55 million people, whatever the dollars are, how do you really bring it down to make change happen? You know, I mean, I struggled with this for 14 years on the staff of the UAW. I became the executive in charge of the General Motors National Account for the Blue Cross Blue Shield system. And we did a lot of good things. But from that level, I kind of always felt like we were pushing on a string, okay, to make things really consumer-oriented, to do managed care the right way. And I ended up finishing my career with Gunderson Medical Center in La Crosse, Wisconsin, which has 400 salaried physicians, is not-for-profit. And I was the CEO of the health plan, but I was a partner with the medical director, 400 salaried physicians. We were able to do managed care the right way. And in 2003, our health plan had the highest customer satisfaction rating out of over 200 Medicare HMOs nationally, because it was driven by the doctors. We had a medical directors committee that made the rules, and when the committee ended, they had to go back and practice medicine to take care of their patients. So, you know, I don't want to be too negative, but I'd be interested in how anybody on the panel, you know, could say, how do you do, when you're starting way up here with all these big federal dollars, and medical care is down here where all the people are, how do you make it happen? How do you make the right thing happen? Thanks.
You know, one thing I would say, and thank you for both the comment and the question and your good work. There are some other organizations represented here in this audience. They and the three of us represent the advocates for beneficiaries, and we don't have the resources. And I'm the founder and executive director of a nonprofit, and Joe and Kevin run nonprofits in the National Committee to Preserve Social Security and Medicare. We don't have the resources, and we're fighting the big guys. If we could get the unions and the others who speak for and to people to explain what's happening to this program. I mean, we didn't privatize Social Security, but we have privatized Medicare. Quietly, it's happened, and it's continuing, and it's not in the interest of beneficiaries and people getting, you know, I'm a lawyer, and we are a law organization. We deal with denials inappropriately of coverage, which we haven't talked about at all today. And that's a whole nother problem. And then the appeal system has been bankrupted. ALJ Solstice, formerly ALJ Solstice is here, can tell you that. And we can't get denials overturned the way we could. So there's myriad problems that are solvable still. What I fear is that they won't be solvable. And there has to be resources put to play to fight back, because it is a very different world than when I started doing this work, when the few organizations could marshal enough energy at least to be heard, along with our dear bigger friend AARP and with the data from Kaiser. But now our resources are barely, it's like David's little cousin versus all the Goliaths. So send us money. Get our materials spread around. Go to our site. Spread the word. Get your congresspeople to care about what's really happening.
I think that one of the answers is that, and one of Medicare's answers to that very question, is devolving more responsibility down to the local level, to the ACO level, to the HMO level. Kind of really in that way saying, you guys take on the risk, or you guys, here's a pot, you guys figure it out. And once again, I talked about black hats, white hats, gray hats, whatever hats you want to call them. Some of these things work. I mean, it's not that. But the problem is, evaluating them all, getting folks on board, understanding, how they're cross-incentivized at sometimes. The complexity of it is I think, growing, and that's a real concern. And at the end of the day, the way you push this program, even though it's so big, is money. And if you say to people, hey, you know what, like we did in the Medicaid program in New York, we want you to stay open at night because most people on Medicaid work. We're going to pay you extra to be, if you do a office visit or something else after 5 o'clock or on Saturdays, and guess what? People stayed open till 7 o'clock, and we're open on, not everybody, but, and you paid them more, and they were open. They were there.
Hi, Leslie Freed, National Council on Aging. And thinking about the whole legislation and ways to improve Medicare, we lost a lot of champions 2 years ago. And I'm wondering if you all could comment on whether what happened with SGR reflected that loss, and what champions you see in the future, because there are still some significant threats to Medicare, especially in the upcoming budget bill.
So why don't you say who the champions are for the benefit of people in the room? I see.
Yeah, Joe and I were talking about that, Leslie, before we convened.
Yeah.
So we named some, Jay Rockefeller, Senator Harkin, Henry Waxman.
Yeah.
They're not, John Dingell, of course.
Pete Stark,
John Kerry, Christopher Dodd, Teddy Kennedy, George Miller. Where are these folks? And we have some good younger folks without seniority, now not in the majority party, quite frankly, but we don't have powerful people. I mean, Rockefeller didn't get it done, but he would at least always be there about, we're not going to ask for the drug companies to negotiate prices, and we're going to do anything on this side first, on beneficiary cuts. I think you raise a very important point. Sherrod Brown is starting to be somebody who we can rely on, who has some authority. Ron Wyden has authority, but isn't clearly a champion. That is, someone who really, in his gut, feels the issues surrounding people with disability, younger Medicare beneficiaries, duals, and older people. Where's Arthur Fletcher?
I'm sorry, Judy, but could you see this as an opportunity? So the older generation's retiring, and there's a new generation coming in. And is this an opportunity for the aging community to really embrace and work with some people and educate some people and have them be your champions?
Yes, absolutely.
If anybody wants to pay for a Super Bowl ad, I'm ready. I want to get somebody to do it. I do think that it is an opportunity, and we use a lot of volunteers at our organization, and just the influx of people over the last couple years has really been invigorating. That and to help other Medicare beneficiaries, that hasn't really translated into a lot of political activity. And when we mentioned the unions and labor earlier, and they've been incredibly supportive in so many ways on Social Security, but also on Medicare and on Medicaid, and even a union like AFSCME, which they got it covered for their people, but they're out there for everybody else, and so. But they're dwindling, they don't have the power that they once had. And so, we really need to find another power source or another people source and another, place where it's easy to kind of get people organized and get them out there. I think there is a lot of, I took some heart that there wasn't more terrible things in the SGR because well, the boomers are aging in, and you just can't sneak this stuff in anymore, or and because people are going to say, whoa, don't touch my Medicare, don't touch my Social Security. There's more of those folks doing that. If you remember the whole Gingrich thing, it was like, we got to get this done soon before that demographic wave breaks into the programs, and guess what? It's broken. So. The wave. So that gives me some hope that there is support for some of the issues that we've talked about and taking care of some of the people we saw on the slides.
I will say one thing. If you think about engaging people who are not yet on Medicare are not so much engaged in the Medicare debate, and so I think one of the issues is helping to engage people 50 and older, people 40 and older, to understand what changes to Medicare will mean for them. And I think it's a hard sell because people who are in that age cohort are just working hard, raising their kids, doing the best they can, while over there in Washington, they're talking about changes to people who are not yet 55 or not yet 60 or not yet 50, them is us. And I think communicating that, for those of you who are communications folks, that's really an issue because people, one way or the other, they might like the policy, they might hate the policy, but it really does matter for them. Lee is giving me like signs, 0 minutes and stuff. Should I say not one? I have one last question in the room.
Thanks. Howard Gleckman at the Urban Institute. I want to give you a hypothetical beneficiary who's not so hypothetical to all of you. 80-year-old widow, multiple chronic conditions, 15 meds, 6 docs. You've all had fairly critical things to say about managed care, but I think there's an argument to be made that someone like this woman needs coordinated care, integrated care, whatever nice word you want to put on it. Let me sort of follow up on Tricia's question about if you were in charge. Tell me what a design for a well-constructed, coordinated care program looks like.
I want to tackle that for both personal and professional reasons. I'm critical of managed care because it has been talking about coordinating care for decades, but it really has proven to manage finances, not manage care, coordinate, not to coordinate care. 2004, we ran a conference called Coordinated Care in the Traditional Medicare Benefit. And I think what people want and need is a primary care physician or nurse practitioner, a caring person who's a medical healthcare provider who knows what he or she is taking and will help that person get to the next step. My husband would tell you that that's a good family physician, or one of his 3 mid-levels, as he calls them. And that's what I think we need, and that's never been what we've gotten in any of the models that have existed through Medicare, be it Medicare Plus Choice, SNP, MA, and that's what we need. We need an identified primary care physician or nurse or healthcare provider who is assigned to that individual, who must know what the person is taking and will help them open the doors to the consulting physicians or care providers they need to go to next. And I can tell you, as a person who had breast cancer, that it was impossible almost for me to know what I was supposed to do when, and that was me, pretty educated, and a family doctor with a husband. And my health insurance had somebody supposedly assigned to me was for useless. So it's you have to focus on coordination of the person's needs, not of the diagnosis and not of the finances. And that person should help them get connected with where he or she needs to go and open doors. That, I think, is what we need.
Anyone else?
Yeah, I mean, I think that's well said. But to us, it's less important who's paying for it, but more what they're getting. And I don't think there's disagreement that, yeah, people deserve that, especially people in the hypothetical you described. They deserve that, that coordination, that care. But how we pay for it, and the assumption has been, since something is labeled as managed care, then that must be what it delivers. But what we find is that that's not necessarily what they've delivered. Now there's efforts to shift the behavior of those organizations to look more like what we say we want it to be, and that's very positive. And I think especially for the dual eligible, there's some opportunity because you've got these two payment sources, and so integrating those and giving someone responsibility with some incentive to shift costs from hospital and institutional settings to other settings is particularly promising. But it's not something that has been done before. It's not something that a lot of these organizations have traditionally done. So we have to recognize that we're asking them to do something different, something aspirational for them, but something that, you know, like Judy said, it's not so much who's paying for it or who's delivering it, but what do they get? And I think there's wide agreement.
I think, you know, we've been very supportive of the Duals project in New York, which is all managed care. It's fully integrated Duals Advantage plans. 26 plans, a lot of plans. But in the hope that we can help shape it, there's a thing called the interdisciplinary team that is supposed to be people from the plan, people from the long-term care providers, and the doctor involved in that person's care, the primary care doctor or cardiologist, that's who's running the care, and getting them to meet, you know, on a regular basis. And a lot of provider pushback on it. A lot of plans saying, oh, who does what? But, you know, that growing pain's fine. But what we've been saying to plans, providers, but mostly to plans is this is the big test of, because, you know, what you're saying to providers is if you provide the care, we'll wrap around all this care coordination. You don't have to hire somebody in your doctor's office. We're going to do that at the plan. Well, let's see. You know, that'd be great. You know, it doesn't, in a certain degree, you know, it does matter who does it. But if it's well coordinated, if there's good communication, you know, let's see if it works that way. Or give the doctors the resources they need to hire the person in-house. I don't care how it's done, once again. But we're monitoring it closely, and we'll see if they really can show that they're going to do this for this dual population, given this, you know, the income streams coming together into this plan with this structure. I hope it works.
So there's another great panel coming up. So please join me in thanking this terrific set of panelists for a great discussion. Thank you. Sorry, I jumped.
I want you to tap on this from the door code.
I'm just going to say very little bit about that. Okay. Very Ross. I think you answered my question. It's sh, not sc. Yes. Okay. Oh, no, I do not. Sorry. I'm trying the question. Okay.
Murray, and then 1, 2, 3. Is that right?
Could I get people to take their seats, and we'll start with our second panel? We are going 1, 2, 3. Okay. If I could ask folks to take their seats, and we'll get going with our next panel. I have to use my... I knew sending Lee out into the crowd would calm things down. So good afternoon, everyone. I'm Murray Ross. I lead the Institute for Health Policy at Kaiser Permanente in Oakland, California. I'm very pleased to be here to moderate this panel and to follow on the great panel we just heard from. The sentiment came up in the previous panel, sort of what's happened to the beneficiary voices in discussions around Medicare policy. And that's an appropriate segue to this panel because we're going to be asking, so what do people want from Medicare? And let's hear about some voices from the field. The panelists' biographies are in your packet. I won't read them to you, but we're going to go from my far right back towards me. Liz Hamill, Director of Public Opinion and Survey Research at the Kaiser Family Foundation. Matthew Greenwald, President and CEO of Greenwald and Associates. And Andrew Scholnick, Senior Legislative Representative at AARP. And again, I'm Murray Ross with Kaiser Permanente. Since I have the microphone, I want to take a couple, maybe 2 minutes to point out something that is in your packet from the Center for Healthcare Decisions. I happen to be on their board, but many of you will know Marge Ginsburg, who's omnipresent in these conversations. And the document that's in the packet summarizes work done in 2013 and 14 with over 80 3-hour med chat discussions. And basically these are deliberative discussions and engagement to test out people's ideas and thinking about, in this case, what might a redesigned Medicare program look like from the community perspective. And people were basically tasked with saying, holding total spending on Medicare constant. They're given like 100 markers that they can use, but they can spend it on 130 markers worth of things. What would you like to add to Medicare, or what would you like to change in Medicare, and what would you be willing to give up to get it? It's, it goes one step beyond what would you like to add if there's no opportunity cost involved, and in this exercise there is an opportunity cost. And I'll just call your attention to a couple things in the results. Because we heard some of them right at the end of the last panel. When people were asked where would they like to increase Medicare coverage, it was overwhelmingly long-term care, dental, vision and hearing, transportation, and mental health. But interesting, a number of the participants in these sessions, and these were not all Medicare beneficiaries, these were young, old, crossing the age spectrum. To assure that, I'll just read this. To assure that Medicare lasts at least another 50 years, 85% of the participants were willing to reduce Medicare spending on current and future beneficiaries. And that's kind of a surprising finding in this work. Within the things of what would you change to improve the Medicare program, the participants, they did not eliminate benefits, but they did accept stricter criteria or new limitations. They talked about requiring enrollment in a provider network rather than the complete freedom of choice now in original Medicare, reducing coverage of low-value care, and again, a hot spot from the previous panel, charging higher income seniors more for Part B premium. So I don't throw this out there as an endorsement, but I throw it out there as some food for thought as you're thinking about our panelists and as we get to some questions at the end of this. So with that, Liz, it's all yours.
Thanks. Is that working? Okay. Thanks, Murray, and thanks, Lee, for inviting me to come speak here today. What I'm going to talk about is quite a bit different. Let's see if I can get my slides. Uh-oh. How about that? Oh, there we go. So I work in public opinion and survey research at the Kaiser Family Foundation, and Lee asked me to set the stage in terms of what we know about beneficiaries' attitudes and priorities, and particularly looking towards the future. And so I do quantitative research on public opinion, so I'm going to show you a lot of data from surveys conducted by the foundation and others. They're mostly nationally representative random sample surveys conducted by telephone. And because we're looking towards the future, instead of just focusing on the views of current beneficiaries, I think it's also important to look at younger adults as well, who are going to be the future beneficiaries of Medicare. So really most of the surveys I'm going to be presenting look at the public as a whole. And I think that deliberative stuff is so interesting. But the data that I'm going to show is kind of showing you where people are right now with all the other things they have going on in their lives, and not having a focused discussion on this, but really where does the public overall stand. One caveat I will make in terms of talking about Medicare beneficiaries is that younger beneficiaries with disabilities are a much smaller share of the population and harder to reach in general public opinion surveys. So most of the data I'm going to show is going to break out seniors versus younger adults, but I don't have a lot of data on younger Medicare beneficiaries with disabilities particularly. So 3 main themes if you review sort of all the survey research on public opinion on Medicare. I don't think any of these will be surprising to any of you or new, but hopefully some of the data points that I'm going to walk through will be useful in framing some of the discussion. So the first is Medicare is popular and perceived to be working well. The public is concerned about Medicare's financial future and whether it's going to be around for them. But despite those concerns, Americans are resistant to most proposed changes to Medicare, and that's particularly true for those that are perceived as scaling back benefits. So starting with the first one, this basically just shows you that Medicare is pretty much universally acknowledged as an important program. The first set of data shows you, if you look at the blue, almost everyone says it's very or somewhat important for their own families. And that's true of older adults, but it's true of most younger adults as well. And when you ask how important is Medicare for the country as a whole, you get almost universal agreement, which is very rare in public opinion research. So that's pretty overwhelmingly supported. We also find that most people, and particularly seniors, believe that the program is working well. So 79% of seniors said that the program is working well for most seniors, a little bit less so among the younger adults, but they're also more likely to say they don't know because they don't have as much experience with it. But we don't just have to rely on seniors' perception of whether it's working well, but if we look at their satisfaction with their health plan among seniors ages 65 and older with Medicare versus younger adults with private insurance, you see that seniors are more likely to say that they're satisfied with their choice of providers, with their co-pays, their deductibles, and their monthly premiums. And this is not to discount any of the data we saw earlier and the fact that we know that there are a lot of affordability and access problems for people, but at least at this point, in terms of plan satisfaction, Medicare is faring pretty well compared to private plans. I thought it was interesting that the one area where there was not a difference in satisfaction is when it comes to the prescription copay, and we know that's the part of Medicare that right now is always administered through private plans. Okay, so moving on to our second theme, the public is concerned about Medicare's financial future. Here's just a question we asked people about their opinion of the financial status of the Medicare program. In 2014, 60% either said the program is in financial crisis or it has major financial problems. So that's a substantial share being worried about the financial future of Medicare. That is down somewhat from about 3/4 that gave those responses in 2009, and that may be somewhat related to the improved projections of the trust fund. More likely, I think it's related to the fact that discussions about reducing Medicare as part of the budget deficit discussions has sort of fallen off the front pages in recent years, so people are hearing less about it. People are also concerned about whether Medicare is going to be around and able to provide benefits for them in the future. And so this is a survey from the Employee Benefits Research Institute asking how confident people are. And 6 in 10, among workers planning to retire, 6 in 10 said that they were not at all confident that Medicare will continue to provide the benefits that it does today. That level, there's somewhat greater confidence among current retirees, but still almost half of them say they don't have a lot of confidence in this. The public, in addition to being concerned about Medicare's financial future, is also worried about what impact the ACA might have on Medicare. And as I was thinking about this yesterday, this was very timely. I saw this op-ed in the New York Times. Obamacare, hands off my Medicare. So there's certainly, some anxiety among people who are getting Medicare now that this expansion of coverage is going to do something to take away from what they have. And so we can actually look at public opinion data that plays into some of that anxiety. We ask people if they think that the ACA is going to leave Medicare better off or worse off, and you see among seniors in particular, they're more than twice as likely to believe that the ACA is going to be bad for Medicare versus good. And then there's also substantial confusion about the ways that the ACA actually does impact Medicare. So there's this death panel myth that will not die. This is as recently as December 2014. We asked people if they think the ACA includes a government panel to make decisions about end-of-life care for people on Medicare, and people of all ages, about 6 in 10 either say that the law does do this or they're not sure. We ask a similar question asking whether people think that the law cuts benefits for people in the traditional Medicare program, and we find the same thing. About 6 in 10 either think it does or they're not sure. So there's a substantial amount of confusion out there. Okay, so we've established Medicare is popular and the public's concerned about its future. And our third theme is Americans are resistant to most proposed changes. So at its most basic level, this can be measured by looking at the share who are not willing to see cuts in Medicare spending. This question was about reducing the deficit and giving people a list of different federal programs and where they'd be willing to accept spending cuts. And Medicare is really at the top of the list in terms of the share that don't want to see any reductions in Medicare spending in order to reduce the deficit. And questions of spending are often break along partisan lines, but the key point here is that the partisan difference is not that big, right? Even 50% of Republicans say they don't want to see any spending cuts in Medicare. So if I showed you a similar chart like this on views on the ACA, the Democrat bar and the Republican bar would be completely different colors. So this is one of those things that there is more bipartisan support. These two questions kind of give you some idea behind why people are not willing to see cuts in Medicare spending to reduce the deficit. 3/4 of the public believes if the president and Congress made the right choices, they could reduce the deficit without major reductions in Medicare spending. And most people think that even if they did reduce spending, they could do it in a way that would not increase costs for people on Medicare. So there's a sense among the public that trade-offs are not necessarily necessary. Okay, so this question shows you some various options that we've asked about in terms of, these are some of the proposals that have been made, cost-saving proposals in terms of changing Medicare in the future. This particular question was asked about these changes as ways to reduce the federal budget deficit, but we've also asked iterations of this question where it was framed in terms of ensuring Medicare's financial future. And there's some differences in responses, but for the most part, the ranking of what people like and what they don't like stays the same, whether you frame it as deficit reduction or shoring up Medicare's financial future. And you see at the top of the list, requiring drug companies to give the government a better deal for low-income beneficiaries is very popular. Anything that cuts into drug company profits is, you know, a winner with the public. So, yeah. But you all know more about the barriers to getting something like that passed. But it does have public support. The next item on the list, about 6 in 10 say they'd favor increasing premiums from higher income seniors, although the caveat to this is that we know from surveys also that most people don't realize that higher income seniors are already paying higher premiums, and we also have done some survey work showing that policymakers' definition of what's high income is not necessarily the same of what people think of as high income, and so while it shows 6 in 10 support now, it's the kind of thing where support could diminish in a political debate over this. The next item on the list is one that seniors are pretty much in favor of, but younger adults not so much, and this is the idea of raising the age of eligibility. So almost 3/4 of seniors who wouldn't, or sorry, almost 2/3 of seniors who wouldn't be affected by this. Fine, raise the age of eligibility, but you know, it gets much less support among younger adults. And then this next one, reducing Medicare payments to providers, is one that gets almost half support among the younger adults, but much less support among seniors. Only about 1/3 are in favor of this, and I think that's likely due to the fact that they're worried about their own ability to access providers, and we heard a little bit about that in the first panel. And then, sorry, I'm The last two items on the list, increasing Medicare payroll taxes, gets lukewarm support. And then at the bottom, you see increasing premiums for all seniors. Any way we ask about this, requiring seniors to pay more out of their own pocket, increasing copays and deductibles, it's not popular among the public at all. I know we heard Judy say in the first panel that Medicare has already been privatized, but there are people out there who would like to see an even greater role for private plans in Medicare, and this is a proposal that's gotten a lot of attention in recent years and is likely to resurface in the future, the idea of changing Medicare to a defined contribution system. We last asked about this in 2014, and you can see across most groups, the majority is in favor of keeping Medicare as it is today. Again, we see a little bit of difference by party ID, but still most Republicans would rather keep Medicare as it is today, and a little bit more support among younger adults, but again, not rising to a majority. But I do want to show you some data suggesting where those who are in favor of a defined contribution plan or some other increased role for private plans may have some room to make arguments to younger adults who have somewhat more familiarity with private health plans. So we asked people whether they think Medicare or private health, the wording of the question was private health plans that people, like those that people get through their jobs. And younger adults are more likely to believe that private plans offer more generous benefits and more choice of providers. And then I just wanted to, thinking about the role of private plans, and I wanted to pull out this little time capsule of showing, remember Part D, the big controversy over that when it was first passed. We had a lot of polling throughout 2004, 2005, 2006, asking how seniors felt about the program, and you can see really up until the end of 2006, more seniors had an unfavorable view of Part D than had a favorable view. By the end of 2006, when more people had been using their plans, that flipped and it was more favorable than unfavorable. We didn't ask this question for a long time, but we flash forward to 2013, and you see that by then it's pretty much for the most part favorable. And so the point here is that any kind of change to a program as big as Medicare that impacts so many people is likely to be met with skepticism at first, and only time will kind of tell what plays out over time. So I know most of the opinion data that I'm showing you is based on, or the opinions about potential changes to Medicare is based on cost-reducing changes, because that's kind of what the recent public debate has been about. But I know there's some interest in finding out how people feel about potential improvements to benefits or things like that. So I don't have a lot of data on that. I did find this from an Associated Press poll, which showed strong support for adding dental and vision coverage. This question was asked about at an extra charge for Medicare recipients. 2/3 were in favor of that. And then this question comes from the Kaiser 2012 survey of seniors, which Tricia designed, which was asking people if you had to pick, kind of that question that she asked earlier, if you had to pick one of these things to improve Medicare, what would you do? And, all of these have a reasonable level of importance, but the thing that people picked most often was improving coverage of nursing home and other long-term care services. I think people know that that can be a really big expense in later life, and they're worried about it. But almost as many people picked adding coverage of dental, vision, and hearing aids, and a somewhat lower share picking adding an annual limit on Medicare costs that seniors pay out of their own pockets. So that's my lay of the land. I really look forward to hearing the rest of the discussion.
Thanks, Liz. Matthew?
Thanks very much. Good afternoon. I hope you'll allow me to quote Abraham Lincoln, just as a way of setting context, who said in his first debate, I think, with Stephen Douglas, quote, "Public sentiment is everything. With public sentiment, nothing can fail. Without it, nothing can succeed." Now, he might have been overstating, but clearly bringing public opinion to bear to the very complex issue of the funding gap coming up with Medicare, I think, is important. And I don't have my presentation, but we can use our imagination. Should I just flip through, or how should we address this? Keep going. It's there somewhere. Aha, there it is. Hope you don't. I went through your presentation. Okay, good. But there's more time for Q&A now, so that's a service. So the question is, we're facing an enormously complex issue in dealing with how to address the funding gap, not only in Medicare, but also Social Security. There are a multitude of ways to address the problem. It's enormously complex, but understanding public opinion as much as possible is valuable. Now, we've seen some very useful findings when we've looked at solutions one at a time without really considering the cost implications of each. And I think there's another research technique that might be applied that can be helpful. Trade-off analysis, also called conjoint analysis, is a technique that has been used often over 30 years in the private sector. In fact, we're doing one now. It's ideal for complex problems. So let me give you one example. I'll give you another one later. People that sell products are really preoccupied with satisfying public needs with the most appealing product. And there's a saying in new product research, the products that are most appealing are the ones that are not profitable, because people want everything and don't want to pay for it. So you have to consider cost. Consider a car. A car can have leather seats or cloth. It can have a 4, 6, or 8-cylinder engine. It can have a great sound system or a good one. It could cost $20,000 or $40,000. What do people prefer? Now, there might be 300 combinations, but it's awfully hard to ask people 300 questions. And there's a technique, trade-off analysis, that can, in 10 questions, estimate how people would answer all of the 300. It's based on Bayesian math, and I was thrilled, frankly, after doing conjoint analysis for 30 years, to see a popular book by Nate Silver, The Signal and the Noise, talking about predictions, good book, where he talks about Thomas Bayes and Bayesian math. So I recommend it. But basically, what conjoint analysis does is it takes, let's say in this case, 1, 2, 3, 4, 5 features, and by carefully aligning the choices, it allows us to isolate the importance of minutes, unused minutes rollover, availability of a new phone every year or not, discounts, and cost, to find out who prefers what and the impact of each one on the final level of preference. That's what trade-off analysis does. It determines the most preferred package and the impact of each change, in this case, when we do it on social insurance, on the funding gap, and it forces realism. We don't only ask people, do you want to add this, but do you want to pay for it? Or do you want someone else to pay for it, which is usually a good idea. Now, let me give you an example, which is available on the NASI website if you want to see the full report. For some reason, NASI was interested in Social Security, and we were pleased to be involved in the study, where we tested 8 policy options to deal with the funding gap. In this case, I think it's 2033, where if nothing is done, we cut the benefits by 25%. That's called an option. But we also tested tax increase, benefit cuts, and benefit increases to see what the public prefers. What's their solution? What's public sentiment? How would they like to solve the issue? In this case, I showed you the question before. We gave them 10 questions like this, carefully aligning the choices. No change was an option in each case. By the way, almost no one wants no change. They just don't want benefits cut by 25%. And we tested the language in focus groups and in cognitive testing to make sure people understood it. Remember that in each case, increasing taxes or decreasing benefits close the funding gap. People like that, as it turns out. Increasing benefits widens the funding gap. Everything was in the context of what it does. And let me just give you a flavor for the detail of what you can find with this approach. So, for example, these are real findings. There's a cap above which working income is not taxed, not subject to Social Security tax. Eliminating the cap over 10 years was a strong positive. Why? Because it reduces the funding gap a lot. Increasing it over 5 years to 90% of earnings is also a positive, but not as much. And no change in that is a strong negative because it doesn't address the problem that people want solved. Now, interestingly, you know, I've heard a lot of people say people don't want to raise taxes. Well, when it comes to Social Security, they'd rather do that than have benefits cuts. So when we suggested raising tax over 20 years by 1/20th of 1% per year, that was a strong positive for the obvious reason. Or raising tax 7.2% in 2022 and 8.2% in 2052, also a strong positive. Not that people love paying more tax or having workers pay more tax, but they love closing the funding gap. In terms of the retirement change, interesting. Gradually raising full retirement age from 67 to 68 is a weak positive. Why? Because it closes the funding gap. But it's interesting, you can even close the funding gap more by gradually raising the retirement age to 70, but that's a bridge too far. People don't want to have to work that long to do it. And I think this gets into the granularity and the fineness of the understanding we can get by using conjoint analysis. Just to give you a couple more examples. Means test, not a positive. No change in children's benefits for students, a weak positive. It doesn't hurt the funding gap. Extending benefits to children whose working parents have died or become disabled up to age 22 is a weak negative. Not a strong negative, but people don't want to pay for that. And last one at the bottom, increasing benefits by $6 per month for all beneficiaries. You think people would love that, but they don't because they don't want to pay for it. It's a negative in the context of everything, every change suggested had a cost. But, however, when we talk about raising minimum benefit to eliminate poverty for 30-year workers at age 62, so they're above poverty, that's a positive. People were interested in that very targeted and willing to pay for that very targeted increase. And also in terms of changing the COLA, they're willing to pay more for increasing the cost of living adjustment for the elderly, which is more, the CPIE is higher than general CPI, and they don't want it lowered. So that's the impact of each of the elements we tested. And the overall most preferred solution, not by everyone, but by 71%, favorable, eliminate the earnings cap over 10 years so that 100% of earnings are taxed, raise the Social Security tax by over 20 years to 1/20th of 1% per year, raise revenues in those two ways, one that other people pay for by and large, one that workers pay for, raise the minimum benefit for lifetime low-wage earners for over 30 years, who were low-wage for 30 or more years, retiring at age 62 or later, CPIE, and this eliminates the funding gap and creates a surplus. This is what the public wants. And I've been told by a few people that this NACI report has had influence on some people. It got some press coverage, and it was effective in demonstrating public sentiment in a way that's effective. And so with that, I think it might be useful to consider this type of approach to see public preferences on how to address the funding gap in Medicare. I think there's high value in the work that we just saw, where it looks at these things one at a time, but we can layer on an extra level of understanding to get a reaction to a variety of ideas for including tax revenues in various and sundry ways, and cost sharing by beneficiaries and other changes in design to the structure of the program. Each idea could be included with an impact on the funding gap, and Kaiser's done a lot of work in this area and has it, and every change would show the impact on the funding gap so we could understand what the public wants and how each idea impacts positively or negatively their overall preference. And then, since the question was already asked, if you could do one more thing, what would you do? So for the funders out there, a study on long-term care, a vital concern where I think it would be useful to measure and demonstrate public preferences would be highly useful. And with that, thank you very much.
Thank you. And now we're going to need to skip back through a few slides.
Yeah, are you able to cue it up, or should I move backwards? Should I move backwards, or are you able to cue it?
I think these
just move back.
Yeah. At least we know where it is.
Okay, thank you. Well, my goal right now is to try to humanize the data a little bit that we're just talking about and bring it down to a little bit more personal level with the Medicare beneficiary perspective in mind. Unfortunately, my slides in the packet don't really mirror what I'm using now. I changed them a few times, so you might actually have to pay attention for a change. I'm sorry about that.
He also gave me a list of questions to ask to test that. So.
I want to start off just quickly refreshing everybody's memory about the Medicare population, touching on what Tricia had said earlier, because it's important to have perspective about who is actually answering some of these questions and what their frame of reference is. So again, there's over 50 million people in Medicare. They're predominantly older than 65, but not exclusively. Many have multiple chronic conditions, which leads to them accessing the healthcare system much more often than the general population. Also, Medicare beneficiaries have significant financial constraints. As we heard, half of all beneficiaries live on incomes of less than $23,500. Half of all beneficiaries have savings of less than $61,400. And the typical beneficiary spends about 17% of their income on healthcare expenses. So essentially, beneficiaries have low incomes, low savings, and high healthcare expenses. But like most consumers, financial considerations affect how they interact with the healthcare system. And individual characteristics color how Medicare is perceived. Each individual has a different lens through which they see the world and how they approach Medicare. So looking at kind of beneficiary perceptions versus Medicare realities, as we heard mentioned, Medicare is generally well perceived and has pretty high satisfaction ratings among beneficiaries. However, beneficiary perceptions are a bit complex. For instance, I think it was noted earlier that 79% of seniors believe Medicare is working well, but only 49% of 18 to 40 or 64-year-olds do. It is possible that low expectations by the pre-Medicare population could mean that people are pleasantly surprised once they become a beneficiary. Several studies have shown that the 50 to 64-year-old cohort have lower opinions of Medicare quality and access than those actually in Medicare. So it's possible that their high opinion now could be based on or influenced by a low opinion earlier. And I think we all realize that saying that something is working better than expected isn't the same as saying something works great. So we just kind of have to take a grain of salt when we see satisfaction. Additionally, there's an element of ignorance being bliss. Various studies have shown that people understand Medicare in general terms, basically that it's a government insurance program for old people. But once individuals are confronted with certain aspects or specifics of the Medicare program, then problems begin to arise. So what are those causes of confusion and frustration? In our experience at AARP, through member interactions and our call center and various other sources, we found that concerns tend to be grouped into two buckets around enrollment and then coverage and benefits, which I've kind of separated by color. Entering Medicare can be scary for many people and present a host of challenges, but then also once in Medicare, there are concerns about how benefits are accessed and used. Some of the common complaints we've had from those entering Medicare are not knowing when to enroll and being hit with late penalties, not understanding traditional Medicare compared to Medicare Advantage, confusing the role of federal government, insurers, and states, as well as being overwhelmed by choices, particularly plan options, but also then once in Medicare, the treatment options available. Again, once in Medicare, people are often confused by the terminology and jargon used, not only medical terminology and jargon, but simply the alphabet soup that usually comes with a lot of the Medicare programs, whether it's DME or whatever phrase you want to throw at them. There's a lot of confusion about what's being talked about. People are also startled to realize that there is no coverage for vision, dental, hearing, long-term care services, and that there's no cap on out-of-pocket costs. In fact, it's out-of-pocket costs that usually cause the most headaches when trying to look at it from the beneficiary perspective. Affordability and cost are sources of perpetual concern. As I noted, the median beneficiary spends about 17% of their income on health care, which was roughly $3,300 in 2010. However, many tend to spend significantly more, particularly those in poorer health, as the chart indicates. Out-of-pocket costs weigh heavily on beneficiaries' minds, both in terms of how much they spend in total, but also understanding where those costs are coming from. And every interaction with the health system somehow has a different cost associated with it. So keeping track is difficult, as illustrated by this chart, which is pretty much just a straightforward presentation of the cost-sharing structure of Medicare. And I think we can all agree that this structure can be pretty confusing. Premiums, deductibles, and co-pays add up even with state and federal assistance, and just making sense of where the charge is coming from can be difficult for many. These cost concerns tend to influence beneficiary behaviors and opinions. We know from our own advocacy experiences that Medicare beneficiaries are most energized by possible changes in cost sharing and access. They experience Medicare most acutely in their pocketbooks rather than in the quality of care they're receiving. And what I mean is that every time we try to activate grassroots or get people interested in a topic, it helps to have it phrased in how it affects their finances rather than how it affects the care that they're receiving, because they understand their pocketbook more than the abstract of quality health care or what's good care that doesn't necessarily apply to them. As such, these concerns about costs and affordability impact decision-making. And beneficiaries, we know, want stability and predictability in costs. This helps them budget and is one less thing to worry about when seeking care. We see this in widespread use of supplemental coverage through MA, employers, and Medigap, particularly CNF plans, which provide first-dollar coverage, although following SGR in 2020, that will no longer be the case for new plans. MA plans have grown increasingly popular as beneficiaries look for cost stability as well as benefits that traditional Medicare doesn't provide. However, we also know that few beneficiaries change their MA plan or prescription drug plans in a given year. Beneficiaries, or I should say year after year, beneficiaries often tell us that once a decision to join a Part C or Part D plan is made, they don't want to make the decision again, even if their needs change or better options become available. In other words, the confusion and frustration is so great that they choose not to relive the enrollment process. I want to further add that beneficiaries are not the only ones who have concerns and complaints about Medicare. Because of the complexity of enrollment, the lack of general health literacy, and the gravity of healthcare decisions, friends, family, and caregivers are often needed for help and support. And confusion and frustration is shared by everybody. It's not a matter of age or if you're actually a Medicare beneficiary. So what do beneficiaries want? The glib answer would be to say that they want everything all the time and for free. But the truth is there are steps that Medicare could take, some of which are already being taken, that would greatly enhance the beneficiary's relationship with the program. Medicare is already trying to advance coordinated care models and make data more available and user-friendly. But bigger changes will require time and energy, but they're still possible. For instance, benefit design could be more simple and enrollment calendars could be better synchronized. And coverage for hearing, vision, dental, and long-term care would improve health and quality of life. Ultimately, Medicare beneficiaries want to be active participants in their own health care, but this requires both access and understanding. They may think highly of Medicare, but we believe that there's still room for improvement. And I thank you, and with that, I think we'll answer questions.
Great. Thanks, Andrew. 3 great presentations, and I was just thinking during the last one, how many people have the same cell phone provider that they've had for 5 years? How about your automobile insurance? I'm 1 year, well, let's just say it's over 30 years with the same company, and they're terrible. and I can't get rid of them because I never have the mental energy to take the plunge. So I know people are going to have a lot of questions, and we'll have some microphones circulating here momentarily. I wanted to ask each of the panelists, this is kind of an oddball question, what in your own findings most surprised you, or in the other panelists' findings? And Liz, I'll give you an example, because I was looking at one of your slides, and this is the 8 in 10 seniors believe Medicare is working well for seniors, yet only half of people under 65 have that same belief. And you mentioned possibly low expectations. I was thinking, is that public discussions about fiscal issues are confusing people about what Medicare is actually doing for seniors as opposed to what it's doing for the deficit? Is it sandwich generation who are confusing what's going on with fragmented care systems and don't understand the social insurance piece of it? But I was just sort of struck at that gap, but once people sort of age into the program, all of a sudden it seems to vanish, and that surprised me. But maybe something else caught your attention.
Well, I would say that actually doesn't surprise me that much, that that younger adults are less likely. I think they're less likely to have an impression of it overall. And perhaps those who actually have an impression of it are those who have helped older adults in their lives with problems they've had, so that may explain why they're less likely to believe it's working well. In terms of what's surprising, I guess actually the slide that I showed on the defined benefit change, I was surprised that there wasn't actually more of an age shift there, because we had asked that question previously and had seen more support among young adults being more divided as opposed to being so much on the side of keeping Medicare as it is. So that's, you know, one thing. I'm not quite sure what's behind that, but.
Go ahead. For me, as I recall, there was some increase in confidence in the financial stability of Medicare recently. And to some extent, it's not surprising, because when we got out of the Great Recession and the economy improves, people tend to import that into their thinking about how everything's going to work out. Nevertheless, we're closer to the running out of the funding of the trust fund for Medicare. And the political system, to some extent, in my opinion, still seems broken, and why confidence would increase, you know, in this set of circumstances was surprising and intriguing, and I think tells us something about how people assess the long-run stability of programs. Anyway, that's the thing that caught my eye.
I mean, I would only add, I think the discrepancy with the pre-Medicare population or the younger population about the recognition that's an important program and they want it there for them in the future, but very different opinions of what's the best way to do that or what the effects of certain policy changes would be when they reach that point. So I haven't spent much time with the younger population, but seeing their perspective is always interesting.
Are there questions in the room? Right up front here.
Thank you. I'm Marion Grant. I'm a Robert Wood Johnson Health Policy Fellow in Leader Nancy Pelosi's office this year. So I have a question for Ms. Hamill. I was struck by the fact, and when we talk about the public's engagement or disengagement on this topic, that your numbers show that people who are younger than 65 don't believe these programs are going to be there for them. And some of them also feel that, well, these could be fixed actually without sacrifice. And I wonder if you think that the combination of those things means that they don't feel like there's a reason to engage. That they're not going to get this anyway, and it could be fixed and no one wants to fix it.
Yeah, that's a great question. I think it's partly that, right? I mean, I think it was Andrew who said they want everything all the time, and you know, but it's partly that, but it's also partly what Tricia talked about earlier. You know, with younger adults, everything, and I say this about public opinion in general, like a lot of the knowledge gaps that we see, I don't blame the public for not having knowledge about these things. They have busy lives. They are worrying about putting food on the table today and getting their kids to the doctor today, and not necessarily thinking about these things. And so they hear one thing in the media about how something's threatening Medicare, and when you ask them that question, they remember that they heard that. And so I think that's probably part of what's going on there. And the other thing, I should have said this at the beginning, all of this public opinion polling that we do, the point of it is not to say that the public is right or that policymakers should follow what the public is saying, but it helps you understand where the public is and what messages they are and are not receiving. And that's just another piece of information that you need to think about when crafting messages to sort of explain why a policy change is really important.
Go ahead.
If I just add a little bit, some of it might be causal too, where people recognize that, or they think that it can be improved and that there's simple changes that could be made without, no trade-offs, but they don't have the faith that it'll get done. And some of that is political disillusionment, and some of it's media impressions and that kind of thing. So the questions are tied together, but there's a balancing cause and effect with them a little bit.
If I can add one thought, I think many people find it very difficult to think through long-range consequences. We see this in terms of saving for retirement. We did a survey and found 60% of people feel they're behind schedule in terms of saving for retirement. Now, that's, there's more than that probably, but that's good. Then we asked them separately, are you doing a good job for preparing financially for retirement? And many of them said yes. They're behind schedule, but there's a rosy something ahead that will all work out, that type of denial. And I think that sort of sense of gap between where we are, where we're headed, and how things are going to somehow magically work out plays in a lot of areas, including their own life.
Okay, we've got a couple out here. I'm going to go to the back, and then to Joe, and then to Judy.
I think Judy and I have the same question, so I'll pass it on. So I was really interested in this.
Will you tell us
my
who you
name's
are?
Leslie Freed, National Council on Aging. I'm sorry. But I was interested in the slide, Liz, on support for various deficit-reducing changes to Medicare. And the highest one was requiring drug companies to give a government a better deal for medications on low-income beneficiaries, which always seems to be taken off the table immediately, never considered. So can you talk about, or maybe Andrew or all of you can talk about that finding and why it gets taken off the table before the table is constructed?
Yeah, I would definitely turn that over to people who know more about the policy issues in the legislative.
It's more of a political question than a policy question, unfortunately. Yeah, no, there's, the short and sweet of it is that the consequences for offering that for a politician are severe than not offering it for a politician, in the sense that the powers that be and the pharmaceutical interests spread a lot of money around, making sure that members know the effects in various ways of some of these cost-saving measures. And frankly, I don't want to phrase it this way, but I can't think of a better way to phrase it. They don't fear the Medicare population, the consequences. Like, it's basically, can you get them to turn out, and does this become an electoral issue? And it never does, because there's so many other priorities. So it's a lot more political, and it's a political cost-benefit analysis for a lot of these members. The polling information is great, though, because that does mean that when presented with that option, the public does favor it. I think there's a lack of presenting it as a viable option, which is something that we could probably all work on. So I'll just leave it at that, I think.
And I would have to chime in to represent some of my colleagues who would point out that best price provisions also have some unintended consequences, so that private insurers can't get a better deal on their own than because the drug companies won't lower the prices, because if they do it there, they have to lower it for all large public programs. So there's a little bit of a cost shift into the commercial population. Joe?
I think I would say there is that, Judy and I were talking about this, France and Canada pay pennies on the dollar, and you're always here, oh, well, we need R&D, and it's like, well, why are we paying the R&D costs of the United States, and France isn't paying a couple pennies more and helping to pay for R&D? So if Costco can, bring the volume to the table. Why can't the U.S. government? But, you know, I'll get off my soapbox on RX. So a couple things. One is that, you know, I do think that folks are still focused on, you know, oh, there's a you know, a place where Medicare runs out of money, i.e. the trust fund, although actually in the last few years the trust fund has actually, you know, extended its life. So I think some of the polling shows that folks aren't as concerned about, you know, Medicare's going broke kind of stuff, which is good for us. The question that I have is, because I don't, you know, look at polling, you know, generally all the time, et cetera, but so this younger population and the fact that they're not engaged, and for all the reasons, I think that's right. You know, I mean, they can't be engaged to a certain degree. Although as boomers age in, they might become more engaged because they're parents, grandparents, et cetera, right? Is there kind of correlated polling or data that shows that they're worried about, they're pessimistic about the future of the country generally? Like, is it a kind of like, oh, the century of American exceptionalism is over, and so, you know, we're just going down the tubes, and Medicare is, you know, going first, you know, and is an economic, you know, pessimism, and so, you know, it's not necessarily about Medicare necessarily. It's like there's not going to be anything around. We're not even going to have electricity, you know, I mean, whatever, you know. I mean, you know, is that, and, you know, you guys look at that kind of stuff more than I do, and just wondered if there's some correlative factor there, which would give me hope that we have, you know, some.
Well, I can comment first, and, you know, I think Liz has some useful data on this. I think that people have heard that Social Security is running out of money and Medicare is running out of money. Now, I've also heard the country's running out of money as well. But I think that, and people have less confidence in Social Security than Medicare, even though Social Security is easier to fix, I think, or at least a lot of people feel that way. I think there's less optimism about these two social insurance programs in the country overall because of the messages that there's serious funding gaps, and that message has been received. Now, it's interesting, on some things, people take no action. Like I've heard a lot of people say, Social Security won't be there for me, quote unquote. Are you saving more because of that? No. But I think it's those messages that make people more pessimistic about those programs than the country overall.
Yeah, and I would say certainly there's plenty of data out there showing that people are worried about the economy. They think things have been going in the wrong direction. But those questions about that, showing that people have anxiety about Medicare's financial future, that's been going on for a long time. And, you know, we actually have seen a softening of how people feel about that at the same time that the economy has been sputtering and only recently recovering more. So, you know, but I do think, yes, people's pessimism is tied into sort of a more general mood of the country as well.
You know, it's interesting to try and tease out the cause and effect in all of this, because you know, you look at what the impact of the slowdown in Medicare cost growth has done, sort of taken the wind out of the sails for a lot of discussions about deficit reduction and you know, Medicare system change or reform. And as soon as it's not on the front pages and on the news, all of a sudden the public opinion catches up and it drops down a notch or two. So, question in the back. The microphone's coming to you.
Larry McNeely with the National Coalition on Healthcare. Thank you all. It's been an informative panel, informative presentations. You know, the dog that didn't bark in the SGR debate was one of the points in the last slide that Andrew brought up, which was the discussion of moving to some kind of combined deductible cap and seeing iterations of that, like the Lieberman proposal, that really just are fundamentally cost shifts to beneficiaries. At the same time, there's, you know, the need to provide a cap and have better benefits. And I'm just wondering, you know, what's old is new again, and what was talked about a month ago behind closed doors is probably going to be part of the debate in the next several months. I'd be interested to see if we can apply some of the wisdom up there about choices and folks' attitudes to how advocates for the program, advocates for beneficiaries engage in that debate and go on offense about improvements that are needed without losing position. So be interested to hear everybody up front talk about that.
Sure. I guess I'll start since I kind of alluded to it earlier. Well, a lot of it does matter on how you present it. And from our perspective, at least, a lot of the previous talk the last several years, particularly going back to all the budget wheeling and dealing in the Obama's first term, presented a lot of these savings options, particularly benefit redesign, as deficit reduction tools and not improvements to Medicare. And that's a huge difference of priorities and perception. And it's a much better conversation to look at it from how can we make the Medicare program better for beneficiaries in particular, but also for the long-term health of the healthcare system, rather than looking at how can we just cut the amount that the federal government is paying for anything, because a reduction in federal spending isn't a reduction in healthcare costs. They're not the same thing. So if we do get to that point where it becomes more prevalent, I know that we will be spending a lot more time publicly talking about what needs to be done to make it a better healthcare program. You know, costs be damned, so to speak. Like if you really want to do it right, it's probably going to end up raising or adding to the deficit, which is not what many on the Hill want it to be used for. So there will be contention if that happens.
And if I can reiterate a point, I think showing public opinion is important and has an impact. And there's great data out there. But I also feel there's another layer that could be effective. And the trade-off analysis on Social Security, I think, did have a positive impact on the debate. And I think there's an opportunity for greater understanding through that type of approach that could have, again, has the potential at least for a positive impact on the debate. Because surely we need to show public preferences on this, and we know that people want a vibrant Medicare system.
Yeah, well, and I would agree on that last one. I mean, civic engagement is an important thing to do to elicit the underlying opinions, but you almost have to do it retail, and it's really hard. It's really hard to do. Tricia.
Tricia Newman, Kaiser Family Foundation. I was looking at the slide of policy options, and Joe and I looked at the payroll tax line and said, 45% support, something like that, would support a payroll tax increase. And that was for deficit reduction, not even to improve Medicare. We all know we cannot provide benefits to people even at their current levels. Forget the out-of-pocket limit, forget any improvements we're dreaming of. Even at current levels, with more people coming on board, the program needs more financing. How does that get on the agenda? Should we be heartened by those findings? How do we begin to talk about the need to finance Medicare to sustain it for the future? Because taxes are a dirty word, and I was actually impressed when I took another look at that and saw 45%.
The one thing I will say about that is, you know, it's one question on a poll before it gets into a political discussion and people start hearing the messages that are going to come about that. And so that's sort of a baseline of how the public reacts when they first hear about it. So it could seem like, you know, a decent baseline level of support, but you'd have to also look at how are people going to respond to the arguments when it becomes a real political discussion.
I don't think you can look at it in isolation. When you have more funding, you get something for it. How do people understand the trade-off? And if there's a need for more revenue, where do people prefer it to come from? There's a lot of different choices, as you know, taxing tobacco, alcohol. There's various. Let's demonstrate what the preferences are. That doesn't mean it's going to translate into a political decision, but it's useful information. I predict that people will be in favor of more revenue, and it will be interesting to see what their preference is for where it comes from.
Did you want to weigh in? Judy?
Judy Stein, Center for Medicare Advocacy. Interestingly, I think we were all struck by this similarly by the data. Things came to our mind, and it's both the support for prescription drug, income from prescription drugs, that is a fair price, a better price, the best price, and the payroll tax. And we recently put together a timeline, which I brought copies of, and I looked at until like 1990, 90, we kept adding to the program. And the notion was to make it better for people, and that there was no free lunch, so you'd have to pay for it. And now that whole discussion seems to be, silly and naive. And it seems to me that it behooves us to try and figure out how to use the information you've all provided us, granted that there are commercial interests that we know are out there, to show people, to try and get heard that if you did this, then you guys, younger and older, might be able to have that, like a dental. And it's not just a checkup. We get these horror stories of people. Everything in your mouth is uncovered. And if we get it covered on appeal, it gets opened by CMS and they uncover it, like from cancer and terrible things. So, and then the prescription drug money. You wouldn't have to keep cutting things if you would get some of this prescription drug costs under control. So I think it's how do we rally the troops to understand that there's something in it for them so that they would be heard, and even though they can't bring the same kind of clout that Andrew's referring to in the halls of Congress. So I don't know yet, but I think it behooves us not to just say, oh, Stein, you're always bringing that up, because your data, Tricia, has given us a way to maybe talk about it better. That is Kaiser's data. So thank you for it. What do we do?
Got a question over here?
Hi, David Goldfarb from the National Academy of Elder Law Attorneys. And to follow up on Judy's point, we've talked, there's often this framing of debt and deficits and paying, but actually the economy as a whole is actually paying for these benefits right now out of private hands. So I was wondering if there is an understanding or any public opinion polling about the out-of-pocket costs that we've talked about earlier, because really what we're talking about would actually be a shift in terms of the person who is actually paying for these $3,000 on average out-of-pocket costs. It would just be a shift to the government. So is there any understanding, do people actually recognize, particularly those under 65, how much folks are actually paying, and that concept that you're actually not getting, it's not actually a cost for the government, it's a shift. Is there any understanding of that based on public opinion polls?
I'm not aware of any polling that asks people if they understand how much seniors are paying out of pocket. What I can say is that for people's own health care and some of the polling we do on Medicare, out-of-pocket costs are a big concern. When you ask people how they want to improve, we just had a poll out recently, not about Medicare, but about people's priorities for healthcare policy going forward generally, and they wanted to reduce prescription drug costs, and they want to make healthcare more affordable. So that's always been and will continue to be a big focus for people. And I think the flip side to what I showed about people being really reluctant to increase costs for seniors, I think if you were to talk about, making things more affordable, that's always going to be popular. I think, the polling gets a lot more tricky when you talk about the shift of cost to government. That's kind of a more complicated concept for people to understand, because then you're talking about a shift in cost to taxpayers too. And so, I think it's an interesting idea to explore. I don't know if anyone else has data that would speak to that.
Sorry. Lee.
Hi, Lee Goldberg, National Academy. I was thinking about polls that I've been asked, that I've gotten phone calls on, and I often get, I don't know what you call it, survey fatigue, right? I just I'll answer a few questions, but I don't want to hang in there more. And I don't know how much of these different techniques rely on polling versus focus groups, if that makes a qualitative difference in what we can say about how we want to improve the program, or how we may want to change the program, or if in fact sort of wearing away at people makes their true preferences come out. I don't know.
I think you definitely need both. I mean, most of what I do is quantitative research, and so I think it is helpful because you can get a representative picture. Yes, our surveys can be particularly difficult to take. Tricia will tell you how many times we try, because we have so many policy experts in our organization, we try to make our question wording very accurate, but it also has to be in a way that the general public can understand and answer. So often our policy folks want to know people's opinions on some really detailed proposal that the public has never thought about, and we have trouble, and sometimes we just don't ask the question because we know we can't get the general public to answer it correctly. But that's the kind of thing you can do with qualitative research and some of these other approaches like the deliberative polling, kind of seeing where people get when they have a discussion with other folks. So I think it's important to use both types of research.
And then you look at how quickly it can all be undone by political campaigns around death panels that, 5 years later are still resonating in public opinion. So I think we have time for maybe one more quick question or one that entails a quick answer. We're getting on to 5 o'clock. Well, no, I thought I was seeing a hand there. Lee had asked me to take a couple minutes to summarize things here. And I just want to say this has been a fascinating afternoon, and I talked to Judy at the break because she had raised the issue of when did it become about the dollars and the providers and not about the beneficiaries. And that was interesting because I hadn't thought about it in this way before, but when you compare the discussions around Social Security and the discussions around Medicare, and I guess my answer is follow the checks. And in one case, they go to individuals, and in the other case, they go to a healthcare system. And that really is what drives so much of the discussion. It's when you look in the trustees' report, lots of charts, lots of numbers, not a whole lot of patient-centeredness, shall we say. I was struck by our panel here, and we see agreement on the gaps in Medicare benefits. We hear, actually, to me, a surprising amount of agreement on sort of some of the fiscal issues and the limitations. The disagreement creeps in pretty quickly on this. So what do we do about it? Because 45% of people like tax increases. So I can't say nobody likes tax increases, but they don't like tax increases on themselves generally. Nobody likes means testing. Nobody likes raising the eligibility age. And nobody understands concepts like delivery system reform because they've rarely seen it actually happen. And the one finding out there that a lot of people aren't sure that actually there's even really a problem that needs to be solved, other than maybe cutting out waste, fraud, and abuse. That there's lots of slop in there, and if we could just figure out how to identify that. But I keep coming back to the discussion of the past couple of minutes, though, is how do you sort of really dig in and help people be aware of what the real issues are, as opposed to the single word hot button issues that make it onto television and in the political speeches. How do you make them aware that there are actually opportunities here to improve care and to improve outcomes and to improve respect? And I think it's incumbent on us to start, reversing the questions and saying, what are we trying to accomplish here? And, who are we trying to accomplish it for? It's just so easy to slip. And I have to say this, I moved to California 13 years ago, and so I come back here and it's like switching languages, right? Come back to Washington and people are talking about the doc fix. And I sort of have to remind them that, that doesn't have any resonance past about Rockville. And the people in this room, the organizations represented in the room, you need to sort of redouble your efforts to get this about the people. And I know we all have to do the job and deal with the policy discussions as they are, but there's an opportunity here, I think, to enhance those and, to draw on the information that's been presented and I think, frankly, just to re-energize. I mean, this is, again, 50th anniversary. Can we make the next 50 years better? That might be the challenge. So it's almost 5 o'clock. Thank you for your attention. Thanks to a great panel for your presentations. And Lee, were you going to dismiss us with any parting brilliance? Okay. Thank you, everybody, for coming. Thanks.